you very much. Assalamu alaikum. So it's very difficult to come after Ayman, to be honest. Excellent talk. So today I just thought, we'll just discuss, how do you manage toxicity of teclistamab, and not only teclistamab, but also other bispecific molecules in myeloma, and even if you're not a myeloma treating physician, I think it's very important to know that you will cover the floor at one day, and we've been using these things more and more, and all of our myeloma patients should receive one of these medications at one point of their myeloma journey. So this is a slide that I know Dr. Ayman is going to present, but I wanted to say, unfortunately, we've got a plethora of options, but as of right now, most of our patients will become penta-refractory after only like 2 relapses. So a third line, they're penta-refractory. So what do we have, and what do we reserve for relapse therapy? And the outcome of our patients in the region, and even international, to be honest, after the third line, their median PFS is very small for any lines of therapy, and median overall survival is less than a year. So it's actually a very unfortunate situation. So what do we have for an approved BCMA-directed therapy right now? So we've got ide-cel, cilta-cel, and teclistamab, and elranatamab. These are BCMA-directed therapy, and they come with pros and cons. And but you can see actually here, these are all new modalities. Just from like 3 years and here. So for your patient who's actually penta-refractory, which medications or which modality of therapy would you give? And we always talk about these things, and I think the real answer is, whatever you have access to. If CAR T is an option, then I think that's probably the first thing that you should actually offer to this patient who's penta-refractory, and then you can actually follow these things with the bispecific therapy. But bispecifics have actually solved a big problem, which is manufacturing issues, delays in manufacturing, patients who are like really proliferative with their myelomas, and they cannot wait until the CAR T is here. So they've actually solved quite a bit of issue. So now these things comes at a cost, and I think at one point you probably with the competition the prices will come down, but if that's the only option you have, then it's definitely cost effective. So in this case, this is one of my patients, and I can tell you clearly that this guy, despite having a normal cytogenetics, this is a very high risk patient who relapsed just 2 years after their transplants. From 2020 till now, they're like penta-refractory. So just from the induction to the first relapse to the second relapse, we've got no options for this nice gentleman. So progressed with the bony disease, which is a common way of presentation, usually in those patients received at the time of relapse. But if you look at this guy in particular, he received a lot of steroid. So he came from, at one point he was doing his relapse therapy in a different place where they're giving him weekly steroid, and he continued for like a year on that. He had multiple hospitalizations with pneumonias. So this is like a very classic guy who's coming, certainly a ticking bomb for an infection. His immunoglobulins has been actually very low. He's lymphopenic at the time of presentation, and he's also refractory to his first line of therapy. So his T cells and B cells are not really functioning really well. So, these are the options that we have in the market. So belantamab vedotin is going to make a comeback, and I'm quite sure about this. So it's an antibody drug conjugate. It will work on some of our patients. CAR T has been an issue in the region. So CARTITUDE clinical trial has been in the region. CARTITUDE 4, and some of the patients has been enrolled in CARTITUDE 4. But ide-cel, I've yet to see any patients on ide-cel outside the States, and I think part of it is because of it required the collection and shipment to be non-cryopreserved. So it's been a technical issue here. Bispecific T-cell engagers are making a really nice breakthrough here, in addition to new antibodies. So, if you actually go back and look at this slide, you can see that, CRS rates has been actually quite high. And in those patients, the numbers are 80%, 70%. But, from our bispecific experience, all of these things are actually grade 1 CRS. So we just really have to know how to navigate this and treat those patients. And neurotoxicity has been very minimal. If anything, it's grade 1, and very rarely to see, beyond grade 3. And just to refresh our memory that CARTITUDE 1, which is the landmark study that got cell-to-cell approved in the landscape of myeloma beyond the 4th line, the amount of side effects is actually quite significant. And in those less than 100 cohort, 17 did not actually reach the time to receive CAR T. So this is an unfortunate event. And the funny thing is, if you actually look at the CARTITUDE abstract, you'll see that the overall response rate is 98%, which is, I believe that, but please count those 17 patients, because those patients did not get yet to receive the cell-to-cell. So pneumonias are actually quite common. Secondary malignancies, people have talked about this, and this is probably part of it because of an underlying chip, plus maybe some CAR T issues, and then all sort of weird and wonderful infections. So the CARTITUDE-4, which is the study that actually been looking at the use of cell-to-cell in earlier lines of therapy, have actually resulted in more or less the same toxicity. So neutropenias and all hematological issues, we can manage. I mean, the problem is that infections. So in the era of COVID, or even after the era of COVID, infections remain really significant. So you're looking at something in the range of 60-70% of those patients, they will get an infection that's grade 3 or beyond. So the Majestic trial, which is the landmark trial that brought teclistamab to the space, in the first cohort, infections also remain to be an issue. So anything more than grade 3, you're looking at 55% of those patients. So I think the take-home message from today's talk is, these are powerful medications. Overall responses are quite excellent, but we really have to know how to manage these side effects. I think it's going to improve overall survival. It's going to actually improve adherence to this medication. We'll probably even minimize interruptions of therapy. So the infections are, they will happen throughout the journey of therapy. So this is even at 2 years. Those patients will continue to have recurrent infections in a rate between 10 to 20%. I mean, they kind of peak at the first year, but even at 2 years, infections remains a concerning issue. This issue has been also seen with the elranatamab molecule. So in the MagnetisM-3, you can see the amount of CRS is actually about 60%, but infections remains a significant issue. So you're looking at 30-40% of those patients, they will have a serious infection. Some of these things could be just a virally induced upper respiratory tract infection, but they also have new signals of new infections. And I'm here talking about some patients having fungal infections, some patients having a CMV reactivation. So these are new things that we have not seen PJB infection in a myeloma patient. So we're seeing this right now. So what are the considerations again to treat this pin-tailor refractory patient? So a CAR T, so a BCMA directed CAR T is an option, and a bispecific. So which one do you use? So I think with a patient who is really heavily pretreated and at risk of infections, probably a CAR T is a better modality to minimize infections. It's a one-time shot. You can actually support them, and pray to God they don't develop post-CAR T, cytopenias. So the summary of infections in all the molecules we have right now is, infections at any grade can happen in almost 30, 40, some molecules can go up to even 50%. These are things that we will see in real life, and we have to manage these infections. So how do you manage this, these side effects? So the lymphoma experience in CAR T has actually taught us significantly about how do you manage CRS. And I think most places are now very comfortable on, just put the grading on the door of the patient, and we just ask, the nurses and the fellows, just every time they go in, they just, grade the patient's CRS and neurotoxicity, and just, put these numbers. So this is a case of, somebody who received teclistamab, and, unfortunately, we undermine the CRS in bispecifics, is mainly when you talk about, blinatumomab and all of these, bispecifics, but, the numbers in the trial is actually quite terrific. So 72% of the teclistamab patients had CRS. So this is a huge number. So assume that all your patients will get this. I mean, the good thing is almost like 99% of those 70%, they had just a grade 1, but we just have to keep this in mind. And if you see the the amount of CRS in all sort of bispecific therapy or BCMA, I mean directed therapy, you can see the numbers are actually really high, 70, 80%. So nothing's too different or unique about teclistamab or talquetamab or irinotelimab. They actually result in high CRS rate. But ICANS are very small, and whether you talk about ICANS neurotoxicity or even non-ICANS neurotoxicity, these numbers are very small, and none of these things have resulted in a long-term complication that make these patients unable to receive this therapy in the future. So infections, you can see it's actually what's even more common than CRS is infections, and these numbers can go as 60-70%, mostly viral infections. So what are the risk factors? I think any myeloma patient who is pentarefractory have got actually this nice cocktail of risk factors. So steroid, a prolonged history of steroid use, they're actually immunodepressed, so they've got a nice milieu for multiple infections. And nowadays, these are the side effects we see in myeloma. So CRS, ICANS, neurotoxicity, infections, and neutropenia. But we've also noticed some delayed toxicity. So like the case Dr. Ayman has presented, a cytopenia that could happen later on at month 8 and 9 and 10. So just keep an eye on these long-term toxicity. So when it comes to CRS, I'm not going to spend too much time here, but you can see that in the teclistamab era, most of the CRS happens in the first day, and almost everybody, if they didn't develop anything at day 3, they will not get a CRS. So those patients, we should actually admit them in the first 1 month, in the first 1 week. So usually by day 8, they're out of the hospital. So they receive the escalating doses of 0.03 day 1, and then this gets a pump at day 3, and then by the end of the week, once they receive the full dose of 1.5, they should be out. And I think the risk of CRS becomes very low, and this is when we transition them to be treated as an outpatient. CRS can have a lot of ways to present. So keep an eye on this, nausea and vomiting and fatigue and headache and hypertension. Just have a very low threshold. Keep in mind that these numbers happens in about 70% of those patients. So this is the the leak grading system that probably everybody is familiar with that, and I'm not going to go through how do we manage CRS. I think the lymphoma group have taught us so much about these things. So the other thing I wanted actually to cover is infections. So infections have been a big problem with those patients. They've actually led those patients to be admitted to emergency departments and to the ICUs, and the numbers have been really high. So see all infections, bacterial, viral, and fungals, 70-80%, impressive numbers. So the amount of hypoglobulinemia that happens from the treatment is also impressive. So 20% of those patients, they will develop an immunodepression on top of their immunodepression from myeloma. And neutropenia can also happen. That's why you see the every now and then use of G-CSF is probably a good idea on those patients. So this led to an international myeloma working group creating a guideline in collaboration with the European group. And in their guideline, they actually wanted to discuss how do we really manage these infections? And these are mainly upper respiratory infections. And the proposed idea now is I think we should really prophylax those patients. So think of those patients are your transplant patients. I think there'll be a time when we think about should we use even letermovir for prophylaxis of CMV, because these things are really coming back as if those are actually in allotransplant patients. So the hypogammaglobulinemia, by definition, is anything less than 500 IgG. And I think the funny thing we have to see is, most of our myelomas are actually IgG. So you really have to know how to subtract the, quantitative immunoglobulin from the SPEP. It happens in quite a bit of patients. 80% reduction in the risk of infections if you actually support them with IVIG. And one of the things we learned from the Majestic trial is that they had actually done a protocol amendment to add IVIG mandatorily in every patient who received teclistamab. So the recommendation is, for antibacterial prophylaxis, those patients should receive some sort of an antimicrobial prophylaxis from the get-go. We should actually think about, acyclovir or valacyclovir for those patients. Antifungal prophylaxis is something that's actually quite recommended, especially in those patients who had the prolonged history of steroid, mainly PJP and other antifungals. And another fungal infections like aspergillosis is not yet to be reported, but I think just keep an eye on those infections. So for bacterial prophylaxis, in those high-risk patients, Bactrim or Septri is recommended. In those who are at risk of viral infections, which is almost all of them, then acyclovir should continue to be used in those patients. We don't actually do a lot of fungal prophylaxis apart from the use of Bactrim to prevent PJP, but fluconazole has also been recommended in some of those patients. So the European group have created this algorithm, and I think our patients actually fall in the high-risk group, by definition. So levoflox is recommended. Fluconazole is something that, or micafungin. The problem with that is it comes in IV, but fluconazole orally is recommended, and oral acyclovir is something that we should do. So my last slide here, I wanted to say, I think we should also look for these infections. So hepatitis reactivation has been reported. Hepatitis C, infection reactivation has been also done, even in those who are treated with HCV therapy, CMV, ABV, and COVID with infections. The last thing is the asymptomatic CMV infection. So there's actually multiple cases of CMV reactivation. We do actually CMV monitoring just out of curiosity, but we don't actually know what to do with a rising titer. I think this is, we're learning with time, and there will be a time when we probably, prophylax, some of those patients. And thank you very much.